Thank you for joining this webinar. Today's topic is going to be zirconia bonding. One of the reasons when they asked me to do a webinar, what I would like to do it about was the amount of questions I get through not only customers of BISCO, but also via social media outlets and a lot of different places where I have contact with dentists from all over the world. And zirconia bonding is a hot topic nowadays. So I choose this topic, and I believe that it can be simplified, even though there are a lot of questions out there. I think that zirconia is still a very young material, and we're still learning a lot about it. So let's do this. This is a little bit about myself. I am a dentist. I am a proud member of the IADR. This is probably the association that I enjoy the most, is International Association of Dental Research, along with the American Association of Dental Research. I would like to disclose that I am manager of the Clinical Research Department of BISCO Incorporated. I've been working with BISCO for a long time, over 15 years. I've done a lot of research on bonding, and now I'm in charge of, sharing the knowledge, or some of the knowledge that we are able to develop at the lab. And I travel all over the world lecturing about bonding and lecturing about adhesive dentistry, and nowadays seems to be a very important topic due to the massive amount of surfaces out there that are used in restorative dentistry. So again, I highlight that because it's very important for the audience to know that I do work for a company. This is my current research. I am looking at finding, or trying to find that beautiful beer, and I haven't been able to find it yet, and that's why I keep trying to find that beer. Just testing. I have my scientific method on beer drinking, and it's not working out so well according to my wife, but I think my results are very consistent. So I keep on applying the same method over and over again. I do like craft beer, and I think it's a wonderful thing. I think that there is no reason to repeat a beer, at least not in the United States. A lot of beer out there, so this is a really nice place to be if you are an avid beer drinker. So let's start with trying to understand that in order to achieve bonding to any surface out there, you need to do two things. You need to generate some kind of mechanical retention, all right? And you need to also generate chemical interaction. Now, mechanical retention and chemical interaction can be achieved in all different surfaces in restorative dentistry. So the process, the thought process is the same. What varies is the method, how you achieve that based on the surface. So for example, if you're thinking about, let's say, lithium disilicate, how do you achieve mechanical retention? Well, you achieve that by etching with hydrofluoric acid. And then how do you achieve chemical interaction? Well, you use a primer such as silane, all right? So you achieve those two things by plugging in different methods. But when you go to for example, a surface like metal, you cannot hydrofluoric acid etch metal, but you still need to achieve mechanical retention. How do you do that? Well, you need to sandblast it. Okay, you're going to achieve that mechanical retention by a different mean. In lithium disilicate, you used a chemical method. As for metal, you used a mechanical method to achieve that mechanical retention. The chemical interaction is always achieved by using a primer, but on metal, you cannot use silane. So you got to use something like an MDP or 4-meta containing primers that will achieve chemical bond to the surface. So it all depends on the surface, but if you understand the process, the method will vary and it's a plug-and-play situation, but you need to understand the nature of the surface in order to be able to achieve the bonding, and that way be a little bit more consistent when it comes down to figuring out what to use and why. All right, so today's lecture, I want to start out with doing a little review of a really, really interesting article that was written by a dear friend, Dr. Nathaniel Lawson, Nate Lawson from University of Alabama in Birmingham. And he had a lot of help from a bunch of really smart people. One of the things that they did on this article was to kind of like evaluate what kind of cement people were using for single unit crowns in the US alone. So they went through the National Dental Practice-Based Research Network. And I think the information in this article is definitely worthwhile sharing, and that's why I'm going to share it with you guys. So basically, they did a survey on 202 dentists from the National Dental Practice-Based Research Network, and they look at, a 3,468 single unit crowns. So, I'm not going to go through the whole article, but I do want to go through some of the results. All right. The results show that 38.1% of those crowns were bonded against 61.9% that were non-bonded. This means that people are doing more of luting, type of procedures in their office, at least, on this sample. And it's an interesting sample size, and of course it has a lot of power because it actually shows a very good how do I say it? A very good view of what dentists are doing right now. So try to figure out what is it that you're doing, and locate yourself in one of these two groups, regarding bonding and not bonding. So one of the things that I gather from these results is that not everything needs to be bonded. You can do dentistry without having to bond everything. Some people believe that they have to bond absolutely everything, but I don't think that's true. I think that what this article is telling us is that a lot of people are capable of doing dentistry and not having to bond 100% of the time when it comes down to cementation procedures. So that's something to look into. Right here, you can see by cement type, the number of crowns that were used. So, when you have your resin cement and your self-adhesive cement, which are the two most used cements when it comes down to bonded restorations, compared to non-bonded, where resin modified glass ionomer is still the most used type of product out there. So, just kind of like to see what is it that people were doing in the study, and maybe you can see and locate yourself and what is it that you're doing. It's quite interesting. Okay. This is something that is very difficult to teach when you're lecturing and talking about the need for bonded or non-bonded techniques when you're going to do a cementation procedure in a zirconia crown or a zirconia restoration, which is what we're talking about. How do you determine proper taper? What is excessive? What is adequate? What is insufficient? It's very complicated, because when you talk to a clinician and you tell them, well, if you have adequate taper, you don't need to really bond. But if you have insufficient taper, you have to bond. But how do you assess that? That is a clinical assessment. That is something that I cannot teach. I mean, I can show images. I can show what the research out there says, talking about anything that is less than 12 degrees in taper and, has at least 3 millimeters in height from a prep perspective, but still a clinical assessment. Nevertheless, it's always recommended to bond to the zirconia surface, not necessarily to the tooth. If you have adequate taper, you don't need to bond to the tooth, but it's always good. It's always better to bond to the zirconia surface, even if you're going to use a glass ionomer, resin modified glass ionomer cement. Okay, so just think about that. Even though you're not going to bond to the tooth, it's highly recommended to bond to the zirconia surface, right? These are some of the materials that have been used, were being used, not some, all of the materials that were used in the study. And as you can see, Emax out there, you know, is 1,012 restorations. But when you start counting zirconia and layer zirconia, it's higher than that. But what was interesting to me was that PFMs are still used and a lot. I read a report from Glidewell Labs where they were saying that porcelain fused to metal use was going down. And this report is based upon their customer base. Okay, it's not based upon, you know, a huge user base out there. But I see that a lot of people, and this is all over the world, are still using porcelain fused to metal as a restorative type of material. There is absolutely nothing wrong with porcelain fused to metal. If a restoration is properly prepped and you have good retention and you have friction between the metal and the prep, and you decide to use zinc phosphate, that is going to work. There is absolutely no contraindication for that. If you decide to use a resin modified glass ionomer cement, that will definitely work. If you decide to use a self-adhesive cement, that will also work, okay? So porcelain fused to metal doesn't have a contraindication whatsoever. It's just a matter of choice. It could be a matter of economics. In a lot of countries, zirconia tends to be way more expensive than a porcelain fused to metal restoration. I am not fully aware what the prices are here in the United States. However, worldwide, porcelain fused to metal tends to be less expensive than zirconia, and people are using it, and porcelain fused to metal has provided a great service. So I don't think that anyone who is in a position like I am, where we have to talk about the newest type of materials and the newest type of the you know, bonding protocols to different surfaces, we should ever discard a procedure or a technique because there is a new one. I think that if you are happy with what you're doing, and most important, you're providing, you know, a good standard of care to your patients, and every time you do a restorative procedure, you believe that you're providing a good service, and then there is no reason for me to say, well, what you're doing is wrong. Well, first of all, I would never say that. But I think that porcelain fused to metal PFM crowns are just fine. PFM bridges are just fine. They have a place. You can substitute those with other types of surfaces, other type of restorative materials. That's also fine. It's also related to the aesthetic demands of the patient. It's related to economics. It's related to a lot of things. But I will never encourage anyone to substitute your porcelain fused to metal crown in the posterior region for a zirconia or for a lithium disilicate just for the heck of switching to a newer material. I think that you can switch, but you need to understand what that switch is going to provide to the patient, and also how you're going to deal with the restorative surface in order to achieve good bonding. One of the biggest issues we get, one of the biggest questions we get, and you can see here, you know, zirconia layered and full contour zirconia, there's a lot of units right there, is regarding to bonding. It's debonding. That is probably the reason why you're listening to this webinar, is debonding. It is very rare to have a porcelain fused to metal restoration debond or dislodge. If it has retention and if it has proper taper, it's going to remain in place. And same thing goes for zirconia, but again, I am not in the business of telling people, oh, well, you should not use PFMs because they're outdated or whatnot. They're just old, but you know, everyone gets old. I'm getting old, and so and all of you are getting old. So you know, there's always something new, and there's always something to learn about the new stuff, and that's what we're going to try to do today. But this is an eye opener, at least for me, because I had never seen this type of number, and it is very significant. So one of the conclusions of this study, and this is the last slide, I believe, that is related to this study, is that 38.1% were bonded with resin cement, and resin cement is the weapon of choice when you're doing bonding procedures. But here is a excessive occlusal tooth preparation, anterior location of a crown, and the use of a glass ceramic crowns were associated with a decision to bond single units. In the anterior region, you have to think about aesthetic demands. In lithium disilicate, which is a glass ceramic, along with feldspathic porcelain, are the weapon of choice in the anterior region. And I think that everybody is fully aware of that. You know, nowadays doing a PFM in the anterior region, unless it's basically because of economics, I don't see why you would not do a glass ceramic type of restoration. They just provide a better aesthetic service, and you can bond it, and these things will last a long amount of time. In the posterior region, it's a different story, but in the anterior region, aesthetic demands become important for the patient and also for us as clinicians. So you need to think about that, your material selection, and where are you going to use it, and why. Okay, so this is, I think this is the last slide about this study. This is a really interesting study. It's a long study. It's very well done. It has a lot of information. It's not commercial at all. It's just, it provides really cool insight of what dentists in the US are doing and also why. Okay. So let's talk about a few things regarding the zirconia surface. You know, zirconia has been used in the biomedical field for a long time, and it started to be used in dentistry about, I want to say about 18 years ago, maybe more than that, maybe a little less than that, but it's been around for a while. The biggest thing with zirconia is that when it came out, it was thought that it was a ceramic. So the only ceramics we had that were widely used were glass ceramics. So the thought process was, well, let's etch it with hydrofluoric acid and silanize it. Well, that doesn't work on zirconia. Hydrofluoric acid etching will not generate mechanical retention on the zirconia surface. And silane will not work because silane requires for you know, a silica component in the surface in order to bond to that component. You know, silane is a double functional molecule that bonds on one end to the silica component of the glass ceramic, and on the other end, it will bond to the methacrylate group or ester group of your cement. So that's why it's considered a coupling agent. Well, silane will not work on zirconia. Now, I've heard a lot of people, lab techs, and also a couple of lecturers talk about how zirconia is a metal. Well, zirconia is not a metal. Zirconium, as an element in the periodic table, is considered a metal. But what we use in dentistry is zirconium oxide. So zirconium oxide is a ceramic, okay? It is a non-etchable ceramic. It will not, you cannot etch it with hydrofluoric acid, okay? So now that you know that hydrofluoric acid doesn't etch, and you use hydrofluoric acid in order to obtain mechanical retention, well, you have to find a different way to obtain that retention. You still have to obtain that because that's part of the process. Now your method has to change because now you have a chemical that does not, you know, cause, you know, any dent on the zirconia surface. So it is a non-etchable ceramic. And also, because it doesn't have any silica, silane will not work. So now it's clear that you cannot treat zirconia as you would treat, let's say, lithium disilicate, Emax. You cannot treat it the same way. Some of you guys are thinking, well, duh, yes, I know, perfect, that's awesome. If you already knew this, that's great. One of the biggest questions I get all the time is, why will silane not work on zirconia? Because it is a ceramic. That's the question. And the answer is, well, it is a ceramic, but it's non-etchable. It doesn't have any silica, so that's why silane will not work. So you need to find other ways to achieve bonding with the proper process and the proper method. All right. Now, you can bond. And this was one of the things that in the past was, let's say, debated, discussed. And there was a moment where people, you know, the community, the research community, everybody said, well, you just cannot bond to zirconia. And that was kind of true for a while. But of course, research evolves. Research is research. You do the research, you do the homework, you generate information, and you keep on going. It's a never-ending, you know, a never-ending road. And we found, and by we, I mean BISCO found, that you can achieve chemical bond and proven chemical bond to the zirconia surface via a interesting functional monomer called MDP. And I will talk about this later on. But you can achieve that. This was published. And because of that, BISCO launched a product, a primer for zirconia, but other companies understood that it is achievable. You can achieve chemical bond, and then everybody started working on their primer, and then actually these primers are now available. There are a lot of companies that have these zirconia primers available in order to chemically bond to zirconia. So nowadays, for anyone to say you cannot bond, well, that's not true. That is definitely not related to the fact that a zirconia crown might fall off. This is related to other things, but the bond is possible via covalent bond, and it is, you know, totally doable by a very simple clinical procedure. Now, here's a kicker. Saliva reacts chemically with zirconia. This is a fact. Saliva, you know, phosphate lipids will deplete bonding sites on the zirconia surface. So think about when you get your zirconia crown from the lab, whether it's sandblasted or not, you're going to try it in. Okay? You're going to try it in. A lot of guys, a lot of clinicians have their sandblaster in their office, but a lot of people don't. A lot of people have their lab do the sandblasting for them. So when you get the zirconia crown or restoration, it's already sandblasted, meaning it already has the mechanical retention, okay? But as soon as you try it in, intraorally, the saliva will react with the surface and it will chemically deplete the zirconia surface from bonding sites. So it doesn't matter what you put on top of it. It doesn't matter how you clean it, you know, it's not going to work. You have to clean it with special products that will achieve a special, how do you call it, environment, okay? And I will explain this a little later. You need to use special products, specific products that are designed, engineered and designed for cleaning the zirconia surface and restoring these bonding sites. I hear a lot of people saying, well, you know, after I try in, I clean with ethanol. Well, ethanol is not going to cut it. I clean with acetone. It's not going to cut it. I put it in the ultrasonic bath. It's not going to cut it. It is not. Because this, you know, saliva will chemically interact with the surface. And now you cannot bond to it, all right? So one of the reasons of, you know, zirconia restorations failing or debonding or just dislodging, you know, falling off, is that maybe during the trying process, the cleaning of that surface was not done properly. So now, even though your best intention is to bond, you're not going to achieve it because it's just not possible. Once it's contaminated, you have to use specific products to remove that contaminated surface and to restore the bonding sites in order to achieve chemical bond. Nowadays, we have this zirconia veneers that are becoming more and more trendy. From a personal perspective, I don't see the gap. I don't see where these things will fit. I think that Emax is doing great. If you want something more aesthetic, and then you go with a feldspathic, but Emax, you can, you know, you can accomplish great aesthetics with Emax. Zirconia, now the super translucent zirconia is becoming, you know, trendy. And this is just one of those things, you know. So if you're going to be doing zirconia veneers, you have to definitely bond these veneers. If some of you guys are doing this, you have to bond them. There is no way that mechanical retention is going to help you. Okay, now you have these zirconia veneers that you could do it at 0.5 millimeters in thickness. So the amount of, you know, prep that you have to do is minimum. Hopefully you're going to be on enamel only. So now you have to bond, all right? There are no undercuts. Everything is very superficial. It's a veneer. Minimally invasive preps. So you have to think about bonding. If you are planning on going and trying to, you know, try these veneers on a patient, or trying to incorporate this type of treatment in your office, you have to understand bonding to the zirconia surface. Otherwise, things are going to get a little messy, because if you don't bond effectively, these things are going to fall. They're just going to fall off. All right. So I'm going to share with you guys a few protocols. All right. There are many protocols out there on how to achieve bonding. I narrow it down to 3 protocols. And this will depend on who does what regarding sandblasting. Okay. So let's say, you know, the surface is sandblasted, okay, by the lab. You get it sandblasted from the lab. You can prime it immediately. You receive the zirconia restoration, and immediately you apply a primer, your zirconia primer, your specific primer, okay? You apply your primer, all right? And then you're going to try it in. The primer will seal the surface, react with the surface, and now saliva will not contaminate the primer. Or, I'm sorry, will not contaminate the zirconia, because the zirconia has already been primed, so you already have a chemical reaction going on. So basically, you try it in, you clean it with, you know, a power wash, you know, with water, and that's it. And then you do your cementation procedure. Whether you do a bonding procedure on the tooth, or whether you decide to use a resin-modified glass ionomer or a self-adhesive cement, that will be your clinical assessment. Again, I'm not here to teach dentistry. I am here to share bonding protocols to a surface. You know, you are the one who's going to decide whether your prep has the proper taper, the proper height, all of that. That will be up to you. If you have, you know, how do I say it, a good taper and a good height, you can, you know, get away without having to do a bonding procedure on the tooth. If you have a short prep, less than ideal prep, and now we're talking about bonding being a must, okay? So your second procedure is when you get the zirconia restoration, and then you try it in. immediately. After you get it, you schedule the patient, and then you try it. Becomes contaminated. So if you want, you can sandblast. Not if you want, you can sandblast it. Okay, this is a protocol considers that you own a sandblaster in your office. All right, so you try it in, you sandblast it, and by sandblasting it, you are removing that contaminated surface. Simple as that. Sandblasted will remove the contaminated surface, from the zirconia. And now you rinse it, and then you prime it, and then you cement it. So the first protocol is related to the fact that your lab is doing the sandblasting for you. The second protocol, you own the sandblast. You have a sandblast in the office, or you have access to a sandblast in the office. So you can try it in. It doesn't matter if it gets contaminated because you're going to sandblast it. You rinse it, you prime it, you cement it, you're good. All right? Now, this is the third protocol, which is related to using a very specific type of product in order to remove the contaminated surface. These products are, and I will mention them both, the ones that I know that exist anyway. So what they do is they generate an alkaline pH on the zirconia surface after trying, and it will remove that contaminated surface. So you try it in, it becomes contaminated, and now you're going to clean it. You're going to clean it. Two products are out there, Zirclean by Bisco and Ivoclean by Ivoclar. Those are the two products that are available that you will be able to use for cleaning zirconia after trying it, after contamination with saliva. So again, Zirclean by Bisco or Ivoclean by Ivoclar, one of the two. So far, these are the only two that I know of that will do this, okay, effectively. These two will work. They will work. They both work the same way, okay? They just achieve this alkaline pH that will remove that contaminated surface of the zirconia, that saliva contaminated surface from the zirconia. It doesn't matter, again, if you try it in and then you put that zirconia restoration in ethanol, in an ethanol bath, or if you power wash it, you won't be able to remove that contaminated surface because it's chemically, it has bonded chemically to the sites of the zirconia surface. So you need to clean it in order to restore these bonding sites. And then after that, you can sandblast it. Okay, you can sandblast it if you own a sandblaster. Okay, and then you rinse it, and then you prime it, and then you cement it or lute it. It doesn't really matter. Now, these protocols, they have, you can have different variations of each one of these. However, the one that most people tell me that they, that they do is that they have their zirconia restoration sandblasted by the lab, but they don't feel comfortable applying the primer and then trying it in after that. They feel that that interaction between saliva and the primer is, it's detrimental to, to obtain good bond. And I understand it's a feeling more than anything. In the lab, we know that if you prime it and then you try it in, you rinse it and you cement it, you're fine. But I understand the feeling. So I usually tell people, if the lab sandblasts the restoration for you, and then you try it in, and then you clean it, okay? So you go from this first protocol, hopefully you can all see my cursor that I'm moving. You lab sandblast it, you try it in, and then you use the cleaning agent. You don't have to sandblast again because it's already sandblasted. You rinse it, you prime it, and you cement it. In that way, you can rest assured that you will have the mechanical retention from the lab. It's going to get contaminated during trying, but by using this cleaner, now you are exposing these bonding sites, and then by applying the primer, and then you're good. Okay, you're good. So there are, in reality, 4 protocols, and the reason I thought about these 3 is because I know for a fact that if the lab sandblast and you receive that zirconia restoration and you prime it immediately, you're good. You're good. However, there's that feeling, where dentists kind of like, well, I don't, saliva and primer, it makes me feel, insecure. I don't know if I'm going to achieve good bond. And then you can, get it sandblast from the lab and then immediately try it in, clean it with a cleaner, and then you apply your primer, and then you do your cementation procedure. Okay? Your sandblast, your powder, your sandblast is very specific. If you own a sandblast, or if you need to, give this information to your lab. 50 micron aluminum oxide, that is what is needed. You need to use 50 micron aluminum oxide, right? Not 75, not 100, it's 50 micron, all right? The research shows that, and we have seen that. If you use something smaller, you're not going to achieve proper mechanical retention. If you use something bigger, you might have some issues with, modification of the surface. Your pressure has to be 40 psi or 2.8 bars, whatever unit you decide you feel more comfortable with. I just read instructions for use of a zirconium primer about 3 weeks ago. They talk about 60 psi, which I think that is probably pushing the limit. 40 psi is what we feel comfortable in the lab working with, or 2.8 bars, and that's what we like to recommend. We never gone above 40 psi, and we achieve pretty good bonding whenever we do any sort of test on the zirconia surface. The time is 20 seconds, all right? It takes about 20 seconds to properly sandblast a zirconia disc, which is about the size of a restoration. In the lab, we don't work with restorations. They're 3-dimensional. They're boxes. The crown is a box. An onlay is a box with a lot of little corners and nooks. We work with flat surfaces, but we kind of like make an educated guess of the size of the disc we like to work with, which will be the size of a restoration, and usually it takes about 20 seconds. The first 2, well, let me finish. The angle should be about 6 degrees, the distance about 2 centimeters. The first 2, the size and the pressure, that's non-negotiable. The other 3, that's negotiable. You want to sandblast less time, that's fine. You shouldn't go over 20 seconds. The angle is something that I can control in a lab setting, kind of difficult to control in a clinical setting, but that's, we recommend that. We don't recommend the blast to go perpendicular to the surface. We recommend to do the sandblasting at an angle. In the distance, you don't want to be too close, you don't want to be too far away. 2 centimeters, we found that it's what it's needed. And this is, all these numbers we have achieved after researching other protocols published by other people and by trying to replicate them in our lab. And this is what we found works the best. But again, the first 2 are non-negotiable. The other 3, that's okay. You can get away with a little bit less time, and the angle and the distance, do your best. Do your best to achieve it, okay? Your primers. These are the 3 primers that I'm going to put here that I'm going to recommend. In the lab, these are the 3 primers that work best. Z Prime Plus from Visco, Monobond Plus from Ivoclar, and Ceramic Primer from Curare. All 3 of those contain MDP, which is a functional monomer. Again, MDP. MDP is a monomer that has affinity for the metal ions. So it works great on metal and also works great on zirconia. Now remember, zirconium oxide is not a metal, but it does have metal ions. So your MDP containing primer will work very well as an adhesive for the zirconia surface. Now, your primer doesn't have to be exclusively a zirconia primer or a metal zirconia primer. You can use MDP containing adhesives, but you have to light cure it, okay? And usually I ask clinicians, how many zirconia restorations are you doing in a month? You know, if you're doing a few, you should have your dedicated primer. Now, if you're doing one every now and then, that you might fear that if you buy a primer, you're not going to be able to use it all because it's going to expire. And then you can use your MDP containing adhesive, but you have to light cure it. A lot of people tell me, do they achieve the same bond strength? No, they don't, but you will get some bond strength, okay? However, when you use any of these three products, Z Prime Plus from Visco, Monobond Plus from Ivoclar, or Ceramic Primer from Curare, you will achieve very good bond to the zirconia surface. Now, you know, the bond is similar. It's similar from all three of them. There are things regarding stability, but I'm not going to talk about that today, okay? These three will work. There are many zirconia primers out there. I have tried a lot of those, and I can feel confident putting these three products in a slide and telling people you can use any of these three, and any of these three will do the work. All right? MDP containing primers. Don't forget that. It is the MDP that will generate the chemical bond, you know, between the zirconia and then your cement, okay? Now, if the restoration is non-retentive, then a bonding procedure must be performed on the prep. I was criticized once by saying, someone told me that, you know, non-retentive shouldn't be the term you use. You should use less than ideal. Again, it's a clinical assessment. It's a clinical assessment. There is no way I can teach people, you know, what a non-retentive or less than ideal prep is, because you might do a prep and think, oh, this is great, this is gonna work just fine. Again, it is a clinical assessment. There are a lot of guidelines out there, a lot. Okay, there are books that talk about the ideal prep. You know, you can go online and look it up, and you can go into YouTube or Facebook now, and you will find people talking about ideal preps. All right, there are CE courses that teach how to prep. Okay, those are available. You should do some of that, if not all of that, and then of course your experience and everything is related to what your assessment is going to, you know, be when you do a prep and you determine, well, this is too short, too much taper, and then this is where you need to do a bonding procedure on the tooth. On the zirconia surface, I believe it should always be done in order to achieve good bond, even if you're going to use a resin modified glass ionomer. And this is, you know, your protocol in one bite. In order to achieve bond, the surface must be clean, sandblasted, and primed. All right, you need to do those three things. Remove all the contaminated surface from the trim that, you know, generated, that is generated when you do the trim. You have to get rid of all of that. Okay, surface needs to be sandblasted, whether it's before or after the trim, but it needs to be sandblasted. And of course, you need to prime it. Those three things are very important, very, very important. And of course, your primer must contain MDP. Other primers, other functional monomers are not as good as MDP. Maybe there will be a better monomer in the future. You know, that's what we're working. That's why we do research. That's why we do synthetic chemistry. That's why we have the ability to be in a lab and, you know, to try different monomers at different concentrations and different concoctions, you know, looking for that sweet spot of formulation and bonding values. So it's a never-ending process. We're always working towards making whatever there is, making it a little better. And it is 7:46. I want to thank you for attending this webinar. It was my pleasure. Unfortunately, we don't have any way to interact during the webinar. I usually don't like to talk for so long without being interrupted. And, you know, I believe that when you are in a lecture scenario, interaction is very important, but I am going to answer some questions. So you can start writing your questions. And, okay. And you can start writing your questions. Let me see. Right here, I get a question. The first question is, let me see, preparation design, bevel or no bevel? Well, again, that's a clinical assessment. That is a clinical assessment. You know, today's webinar was not about prepping. It was about how to achieve bonding to the zirconia surface. So that's up to you as a clinician. Difficult to say. It all depends on the case. I've heard some people say that you shouldn't bevel. I've heard some people that actually do butt joint. I've heard it all. So I really don't have an opinion on that because that's more of a clinical assessment and it's up to you as a clinician. Will sandblast weaken zirconia? It can, depending on the pressure, depending on the size of the particle size of your powder, depending on the time that you sandblast. Yes, it can. So that's why I gave that very specific protocol, because we found that when we do the blasting with 50 micron aluminum oxide at 2.8 bars for 40 psi for 20 seconds, there is no modification of the surface. Anything beyond that, you know, we believe that you could have some problems. And there is research out there that shows that. So sandblasting will weaken zirconia, yes, but it will depend on, again, the particle size of the powder, the pressure, and the time. What MDP adhesives would you recommend? I work for a company, so recommending a product, I am very biased, but I will tell you that think about companies that make a living out of doing research on restorative materials, you know, such as Bisco, such as 3M, such as Curares, you know, such as Ivoclar. Those companies usually have very good adhesives that will work, they will do the job. There are other companies out there, smaller companies or companies that have adhesives in their product offer. You know, that's something that is up to you to decide based upon what, you know, the research says and based upon what other colleagues recommend, or maybe based upon a lecture that you hear, you know. But I will always recommend people to use products from companies that have certain prestige. Don't buy products or don't use products from weird companies out there, okay? I heard that scoring the integrity of the surface is advised with water on. I wouldn't go there. I wouldn't go there. There is conflicting information regarding that. I wouldn't go there. I would just sandblast it. That's what I would recommend. Okay. Will light go through zirconia? Tough question. Tough question. It depends. You know, you have different types of zirconia now. In some zirconia are more translucent than others. So it depends on the type of zirconia. But if you're talking about like a monolithic bruxer, absolutely not. Light will go, it will be very, very little, the amount of light that goes through it. I would recommend for you guys, if you guys have an Instagram account, some of you, follow Dentinal Tube, or I'm sorry, Dentinal Tube on Instagram. That is Nate Lawson's account. Follow him. He posts a lot of things about zirconia and a bunch of cool stuff about the research that he's doing in the lab at UAB. So follow him, and he just posted something about light going through zirconia. Really, really cool stuff. Can you show a rest of the bonding technique? I already did. You can listen to this webinar again. You have 3 protocols plus the protocol where you do. Okay, let me put it this way. Simple. If the lab does what do you call it? If the lab does the sandblasting for you, you get the zirconia restoration, schedule the patient, try it in. It's contaminated. Now clean it with Zirclean from Bisco or Ivoclean from Ivoclar. Then place your primer, then do your cementation. Done. Done. So you need 2 products. You're going to need the surface cleaner, and you're going to need the MDP containing primer. Okay? And that way you don't have to worry about sandblasting. That way you don't have to worry about contamination. That is probably the most, how do I say it, easy to follow. All right? Very, very simple. Sandblast it by the lab, try it in, clean it with Ivoclean or Zirclean, rinse it, apply your primer, you're good to go. Do you still need to prime if only luting zirconia, not bonding? If you're bonding, okay, if you're not bonding to the tooth, I would say yes. I have seen some research done by Nasser Barji and others where they show that when you prime zirconia and use resin modified glass ionomer, you achieve better bond strength. However, there are a lot of self-adhesive cements out there that bond to zirconia. You know, you have your Unisem 2 from 3M that does a pretty good job. You have your Panavia. You have your Theracem. Panavia is from Curare. Theracem is from Bisco. Panavia and Theracem have MDP incorporated into the cement. So not necessarily. But if you don't have let me put it this way. If you don't have Panavia or Theracem, which have they already have MDP in their formulation, I will recommend that you use a primer, even if you're doing a luting procedure with resin modified glass ionomer. Bonding to the tooth surface is going to vary based upon the retention or the prep, you know, the prep. If your prep is less than ideal, and then you're going to need to bond to it. Etch the tooth. This is not about it's not about bonding to the tooth, but I will tell you, I do not use phosphoric acid, nor recommend the use of phosphoric acid on dented, on enamel only. But that will be something for a future webinar. I always prime the prep. Is that okay? Yes, that is totally okay. If you sandblast, prime, then try in. Is there any value in cleaning with Zirclean or similar cleaner? Will it affect negatively if you do? If you sandblast, prime, then try. Nope, you're good. You're definitely good. Good to go. As long as you feel that, as long as you know that priming that surface first, when you try it in, it's not going to become contaminated, you're good to go. Do you recommend to apply a primer or bonding to the prep? Again, it depends. It depends on the preparation itself. If it's retentive or less than ideal, it's up to you. That is a clinical assessment. just to make sure, a retentive 2 to 3 degree prep can be cemented with glass ionomer. Is there any advantage to using cleaning before such cementation? Lastly, what is the post-cleaning protocol? Yes, you can use a glass ionomer, 2 to 3 degree prep. That's pretty parallel. You also have to consider the height, the height of your prep, how long it is. Is there any advantage using the cleaner before such cementation? Yes. If you're going to prime it, prime the surface, yes, there is an advantage, because the advantage is that you are exposing new bonding sites in order to be able to prime it and achieve chemical bond to the zirconia surface. What is the post-cleaning protocol? Rinse it, dry it, apply your primer, you're good to go. Where does silane come in? It does not. Not in today's webinar. I'm sorry to say, if you're a silane fan, it doesn't come in. Silane comes in when you're doing lithium disilicate or when you're doing feldspathic porcelain, but not today, baby. In our country, a lot of dentists still use glass ionomer for zirconia. Is it acceptable as well, or is priming and resin cement better? If you have retention, you don't have a problem. The problem is when you have less than ideal. Again, always recommend to prime the surface, even if you're using resin modified glass ionomer. If you're using glass ionomer, powder liquid, then using a primer is not going to help you in any way, shape, or form. But if you're doing resin modified glass ionomer, yes, you will have a benefit. If you use Theracem, it does not require prime. No, it does not. It does not, because a Theracem has MDP as a functional monomer in the formulation of the cement. Does MBP help non-resin modified glass ionomer retention? I don't understand the question. I have to assume non-resin modified glass ionomer retention. I don't understand. I don't understand what non-resin modified glass ionomer retention means. I'm sorry. You have to understand, English is my second language. That's why I speak funny. Hey, if I speak funny, it means that I speak at least 2 languages. So we're good, baby. Well, I think we're done for today. It's 7:59. I was told that I had 1 hour. I have answered every single question that came in this little chat room. So it has been my pleasure. I hope you guys get your C credit, and thank you for joining, and thank you for listening. Have a good night.